Hello, future nurses and NCLEX achievers. Welcome back to NCLEX, the platform where your nursing preparation transforms into confidence, clarity, and clinical excellence. Here, we bring you 2 to 3 advanced NCLEX videos every single day, packed with evidence-based content, real-world clinical reasoning, and NCLEX pearls that help you learn smarter, not harder. In today's urologic nursing session, we are focusing on a common yet often misunderstood condition: urinary incontinence. This topic is not just about bladder control, it's about restoring dignity, independence, and quality of life. In this session, we will explore the different types of incontinence: stress, urge, overflow, functional, and reflex, and discuss the pathophysiology behind each. You will learn essential assessment findings, diagnostic procedures like bladder scanning and voiding diaries, and priority nursing interventions including bladder training, pelvic floor, Kegel, exercises, timed voiding, and pharmacologic management. We will also highlight key client education points and preventive strategies that are frequently tested in NCLEX and critical in real-life nursing care. So stay tuned till the end and take notes, because mastering this topic will strengthen your understanding of elimination patterns, geriatric nursing, and client-centered care. And always remember, at NCLEX, we do not just teach nursing, we prepare you to care with empathy, act with precision, and think like a nurse. Let's begin today's empowering session on nursing care of clients with urinary incontinence. Hey, future nurse, before we continue to our next NCLEX topic, I want to quickly share something that might just make all the difference.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us smoothly transition into our next scenario, which highlights a crucial concept in rehabilitation nursing. A 68-year-old client recovering from a cerebrovascular accident, or stroke, has been admitted to a long-term rehabilitation facility for bladder retraining due to functional incontinence. The client demonstrates mild cognitive impairment and right-sided hemiplegia, but retains full comprehension abilities. Before initiating the bladder retraining program, which nursing assessment should take top priority to ensure the plan is both individualized and evidence-based? Moving forward, here are the options for you to consider carefully. Option 1 suggests recording the times at which the client is incontinent. Option 2 involves checking the specific gravity of the urine. Option 3 proposes monitoring the extent of bladder distension through palpation or a bladder scan. And Option 4 recommends weighing the client's incontinence pads to measure urine output. The correct answer is Option 1, recording the times at which the client is incontinent. Now, let us explore the expanded rationale in depth. Before initiating any bladder retraining program, the nurse must establish a detailed understanding of the client's voiding pattern. Recording the exact times when incontinence occurs provides a vital baseline for identifying urinary elimination trends. This data allows the nurse to implement habit training or timed voiding, core elements of bladder retraining, by scheduling toileting intervals that align with the client's natural bladder rhythm. Such structured approaches are particularly beneficial for clients with neurologic impairments, including those recovering from stroke, multiple sclerosis, or spinal cord injury. By mapping out patterns of voiding and leakage, nurses can create a personalized toileting schedule that minimizes accidents and promotes continence. Continuing on, for a stroke patient, bladder retraining is not just about physical care, but also cognitive and behavioral reinforcement. The nurse must assess whether the client recognizes bladder fullness, can use the call bell system appropriately, and is able to safely transfer to a commode or toilet. Once a pattern is identified, toileting can be scheduled every 2 to 3 hours and gradually extended as control improves. This consistent documentation also helps pinpoint external factors, such as diuretic administration, fluid intake before bedtime, or mobility limitations, that may exacerbate incontinence. Through this data-driven, individualized approach, the nurse fosters continence restoration, reduces infection risk, prevents skin breakdown, and enhances the client's dignity and confidence. Let us now review why the other options are not appropriate. Option 2, which involves checking the specific gravity of the urine, primarily assesses hydration status and kidney concentration ability, but does not reveal the timing or frequency of incontinence. Therefore, it lacks the behavioral insight needed for retraining. Option 3, monitoring bladder distension through palpation or bladder scan, helps identify urinary retention or overflow incontinence. However, it is a diagnostic assessment, not a foundational step in bladder retraining, as it fails to reveal habitual voiding patterns. Lastly, option 4, weighing incontinence pads, is useful for measuring urine output and maintaining fluid balance, but does not indicate when leakage occurs, which is essential for creating an effective toileting schedule. Transitioning now to our professional takeaway, Stand Coast Pearl. Pattern precedes progress. Before retraining the bladder, train your observation. The bladder diary is the nurse's map to continence recovery. Now, moving ahead to the next layer of understanding, clinical insight. Bladder retraining is a delicate combination of neuromuscular re-education and behavioral conditioning. For clients with neurological deficits, timely and accurate assessments are key to preventing complications such as urinary tract infections, moisture-related skin damage, and psychosocial distress. By identifying and documenting elimination patterns early, nurses transform clinical data into personalized care, restoring both control and confidence. Let us now shift our focus to another essential ethical and legal nursing scenario that frequently appears in examinations. As part of routine patient care, several residents are seated near the nurse's station when the nurse overhears a patient care technician, or PCT, exclaim in a loud, irritated voice, "He's wet again! Why can't he ever stay dry?" The nurse instantly realizes that this statement was audible to other residents and staff members nearby, which raises an important question about professional conduct and client privacy. Based on the nurse's understanding of patient rights and federal regulations, which federal law has the patient care technician violated? Here are the options to carefully consider. Option 1, Good Samaritan Act. Option 2, Hippocratic Oath. Option 3, Health Insurance Portability and Accountability Act, also known as HIPAA. Option 4, Emergency Medical Treatment and Labor Act, abbreviated as EMTALA. Correct answer, Option 3, Health Insurance Portability and Accountability Act, HIPAA. Now, moving forward to the expanded rationale, this situation clearly represents a breach of the Health Insurance Portability and Accountability Act, or HIPAA, a federal law enacted in 1996 to protect the confidentiality, integrity, and security of patient health information, collectively referred to as Protected Health Information, PHI. To begin with, PHI includes any data that can identify a client, such as their name, address, birth date, medical record number, diagnosis, or even verbal statements about their health. In this case, by publicly announcing the client's incontinence in a shared environment, the PCT disclosed sensitive personal information without consent, violating both legal and ethical nursing standards. Furthermore, HIPAA mandates that all healthcare workers, whether licensed or unlicensed, handle patient information with utmost discretion. This means that discussions about patient conditions, diagnoses, or care must always occur in private areas, away from public or semi-public spaces. Therefore, upon noticing this violation, the nurse must act immediately by educating the PCT about confidentiality standards, reinforcing the professional code of conduct, and documenting and reporting the incident according to facility policy. This prompt action maintains patient trust, upholds legal compliance, and promotes a culture of accountability within the healthcare team. On the other hand, it is equally important to clarify why the other options are incorrect. The Good Samaritan Act provides legal protection to individuals who voluntarily assist in emergencies outside of clinical settings. It does not relate to breaches of privacy. The Hippocratic Oath, traditionally taken by physicians, is an ethical pledge emphasizing do no harm and maintaining confidentiality, but it is not a federal law. Lastly, the Emergency Medical Treatment and Labor Act, EMTALA, ensures hospitals provide emergency care regardless of a patient's ability to pay, but does not address issues related to confidentiality within long-term or inpatient care environments. Now, transitioning smoothly to the reflective learning point for this question. Stan Coast Pearl. Confidentiality is the invisible shield of trust in nursing care. Every conversation a nurse holds about a patient must honor privacy, even when it seems harmless. Protecting patient dignity is not just about compliance, it preserves trust, professionalism, and the moral foundation of nursing practice. Transitioning now to our clinical insight for deeper understanding, confidentiality breaches are among the most frequent HIPAA violations, often resulting from casual hallway discussions or loud exchanges at nurses' stations. Nurses must consistently model professional communication and ethical awareness, demonstrating to unlicensed assistive personnel how to maintain discretion in daily interactions. By fostering awareness, creating private communication spaces, and reinforcing confidentiality, education, nurses safeguard not only patient rights, but also the integrity of the entire healthcare team. Let us now transition into an important ethical and legal nursing situation that often appears in examinations and real-life clinical practice. Imagine this scenario carefully. A client in a long-term care facility is participating in a structured bladder retraining program after a stroke. One afternoon, the client's niece visits and, out of concern, asks the nurse, "How is he doing? Is he making progress with his bladder retraining?" As a professional nurse who upholds ethical standards and legal accountability, which response would be the most appropriate in this situation? Here are the available options to consider thoughtfully. Option 1 states, his bladder retraining is coming along, and before long he will be urinating like normal. Option 2 says, he seems to have more incontinence in the afternoon and evening. Option 3 states, in order to protect his privacy, I cannot give you that information. And option 4 says, bladder retraining is slow work. We have to take him to the toilet every 2 hours. The correct answer is option 3. In order to protect his privacy, I cannot give you that information. Now moving forward to understand the expanded rationale in depth. This question focuses on the Health Insurance Portability and Accountability Act, widely known as HIPAA, which is a federal law designed to safeguard all forms of protected health information, PHI. Under this law, nurses and healthcare providers are both legally and ethically bound to maintain strict confidentiality regarding any details that can identify a patient, including their diagnosis, care plan, progress, or personal data. In this situation, although the niece's inquiry comes from genuine concern, it involves the client's medical progress, which is protected information. Therefore, the nurse must respectfully refuse to disclose these details and instead reinforce the importance of patient privacy, exactly as option 3 demonstrates. Let us take a moment to analyze why the remaining options are incorrect. Option 1 might sound reassuring, but it clearly discloses confidential progress information about the client's bladder training, which breaches HIPAA standards. Option 2 exposes behavioral and continence data, a form of PHI, that should not be shared with anyone other than authorized personnel or the client. Option 4 goes even further by describing the care plan details, revealing specific interventions that also constitute private health information. Sharing such information violates the ethical principle of fidelity, which involves faithfulness to the patient's trust and respect for autonomy. Continuing with a broader perspective, confidentiality in nursing practice is not limited to written charts or electronic health records. It also extends to verbal communication, such as hallway conversations, casual discussions, or phone calls that others might overhear. Nurses must consistently redirect such inquiries toward the proper communication channel. For instance, encouraging the niece to obtain updates directly from the client or an authorized representative. Maintaining confidentiality is not merely a regulation. It represents the heart of professionalism and ethical nursing conduct. Even unintentional violations, such as talking about patients in public areas or leaving open medical charts, can result in disciplinary action, monetary fines, or even license suspension. In addition, the nurse holds an educational responsibility to inform other healthcare workers and family members about privacy protocols. This promotes a culture of trust, respect, and accountability within the healthcare setting. Every action that guards a patient's information strengthens the ethical foundation of the nursing profession. And now, let us conclude with a Stan Coast Pearl. Confidentiality is not secrecy. It is respect for trust. Every time a nurse safeguards a patient's information, they honor the faith placed in them and uphold the essence of compassionate, ethical care. Always ask yourself, if this were my family member, would I want this information shared? Transitioning now to the clinical insight. HIPAA protects all identifiable health information, whether spoken, written, or electronic. Even well-meaning relatives must have patient authorization before being given updates. Nurses play a vital role in educating unlicensed personnel and visitors about privacy standards. Common HIPAA violations include discussing patient cases in public spaces, leaving screens unlocked, or mentioning patients on social media. By serving as ethical role models, nurses ensure legal compliance, patient trust, and the highest level of professional integrity in every interaction. Wait a second before jumping to the next NCLEX topic, because this could be the biggest boost to your preparation.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let's make your next attempt your last one. Let us now smoothly move into this important nursing scenario that focuses on therapeutic communication and evidence-based client education during bladder retraining. Imagine this situation. A male client recovering from a stroke tells the nurse, "I have decided to drink less water so that I can stay dry longer and avoid accidents." As the nurse implementing this plan of care, which response demonstrates the most appropriate and therapeutic approach? Here are the options to consider carefully. Option 1 says to encourage the client to restrict fluid intake as it supports bladder control goals. Option 2 recommends supporting the client's effort to limit fluids because it promotes continence and cooperation. Option 3 suggests advising the client to avoid excessive fluids only during the night to prevent nocturia. Option 4 advises discouraging the client from restricting fluid intake because it can lead to fluid imbalance and urinary complications. The correct answer is Option 4. Discourage the client from restricting fluid intake because it can lead to fluid imbalance and urinary complications. Now, transitioning into the rationale, it is essential to understand that bladder retraining is a process designed to help restore normal voiding patterns by gradually extending the time between urinations while keeping the body well hydrated. Encouraging a client to reduce fluid intake may seem logical for controlling incontinence, but in reality, it causes the urine to become concentrated, leading to irritation of the bladder lining. This irritation increases the urge and frequency to void, which completely defeats the goal of bladder training. Furthermore, adequate hydration plays a crucial physiological role in maintaining renal perfusion and preventing urinary tract infections. When a client reduces fluid intake, urine stagnates in the bladder, allowing bacterial growth and the formation of renal stones. Over time, this may result in complications such as dehydration, constipation, and electrolyte imbalances. Hence, the nurse's role is to explain that sufficient fluid intake actually supports the success of bladder retraining rather than hindering it. In addition, from a neurological perspective, dehydration can worsen fatigue and cognitive function in post-stroke clients, delaying their rehabilitation progress. Therefore, the nurse should prioritize teaching the client about healthy voiding intervals, scheduled toileting, and pelvic floor exercises instead of fluid limitation. This approach not only addresses continence, but also ensures safety, comfort, and overall recovery. Moving on to why the other options are incorrect. Option 1 is incorrect because restricting fluids may appear cooperative, but is physiologically harmful. Reduced hydration increases the risk of urinary infection and concentrates the urine, which irritates the bladder. Option 2 is also incorrect, since supporting the client's plan favors short-term dryness, but goes against the nursing ethical principle of non-maleficence, meaning do no harm. Option 3 is partially correct in terms of limiting fluids at night to prevent nocturia, but advising restriction during the day can cause dehydration and urinary stasis, making it counterproductive. Transitioning now to the clinical insight. Effective bladder retraining focuses on timing and consistency, not fluid restriction. The goal is to strengthen bladder capacity gradually by maintaining a regular schedule and ensuring proper hydration. Nurses should educate clients that staying well hydrated helps the urinary system flush out toxins and bacteria, keeping the bladder healthy. True continence is achieved through discipline and consistent practice, not through limiting essential fluids. And moving forward to the final thought for this topic, Stan Coast Pearl. Restricting fluids to stay dry is like skipping meals to lose weight. It harms more than it helps. Hydration is the foundation for kidney, bladder, and brain health. Real bladder control is built through patience, training, and proper hydration, not deprivation. Let us now move into a deeply emotional and insightful nursing situation that highlights the true essence of therapeutic communication in geriatric care. During a calm morning assessment, a 72-year-old client with urinary incontinence looks at the nurse with quiet despair and says, "What is the sense in living? I am just a baby nowadays." In this sensitive moment, as the nurse providing compassionate care, which response would best demonstrate therapeutic communication and effectively support the client's emotional well-being? Here are the possible options to consider carefully. Option 1 states, "You are a very nice person." Option 2 says, "Cheer up, you cannot be serious." Option 3 suggests, "You should expect this at your age." And option 4 responds, "You are discouraged right now." Now, moving forward to the correct choice, the best answer is option 4. You are discouraged right now. Transitioning into the expanded rationale, this question focuses on the art of therapeutic communication and the nurse's ability to respond empathetically to emotional distress. The client's statement reflects hopelessness, a sense of loss, and regression linked to urinary incontinence, which can deeply affect dignity and self-worth. Option 4, reflecting the client's emotion by saying, "You are discouraged right now," demonstrates the therapeutic technique of reflection of feelings. This technique acknowledges and verbalizes the emotion behind the client's words, validating their emotional experience and showing that the nurse truly understands their inner struggle. Such validation opens the door for deeper conversation, trust, and emotional healing. It reassures the client that their feelings are real and worthy of expression, fostering a sense of safety and connection. In addition, reflecting emotions allows the nurse to assess for possible depression or suicidal ideation, ensuring timely mental health intervention if needed. On the other hand, option 1, "You are a very nice person," is non-therapeutic because it offers false reassurance and diverts attention from the client's emotional pain. It fails to address the root emotion and may make the client feel dismissed or misunderstood. Similarly, option 2, "Cheer up, you cannot be serious," minimizes and invalidates the client's feelings, which can block further communication and reinforce emotional isolation. Finally, option 3, "You should expect this at your age," reflects ageism and insensitivity, suggesting that suffering and loss are normal parts of aging. This statement strips away empathy and diminishes the client's sense of self-worth, worsening their emotional distress. Broadly speaking, urinary incontinence in elderly individuals is not just a physical problem. It also carries emotional consequences, such as embarrassment, anxiety, social withdrawal, and loss of confidence. The nurse's role extends beyond physical management. It includes restoring dignity and emotional balance. Effective nursing interventions include scheduled toileting, pelvic floor exercises, hydration management, and psychological support through empathy and open communication. Therapeutic communication strategies like active listening, reflection, and empathy can transform the client's experience from isolation to empowerment, while also helping nurses detect hidden depression or emotional burnout early. Transitioning to the deeper takeaway, clinical insight. Therapeutic communication is not about removing pain, it is about acknowledging it. When the nurse reflects the client's feelings of discouragement instead of brushing them aside, it opens the door to healing. This simple acknowledgement can uncover deeper fears of aging, loss of independence, and identity changes, guiding the nurse to offer holistic support that nurtures both body and mind. Moving to the final key point, Stand Coast Pearl. Validation heals more than reassurance. When a nurse recognizes and names what the client feels, it transforms silence into connection and suffering into trust. Reflection of emotion is not merely communication, it is compassion in action, a bridge from despair to dialogue, and one of the most powerful tools in nursing care. Let us now explore another practical NCLEX-style scenario that evaluates your clinical judgment during bladder retraining care. Imagine a situation where progress has been slower than expected due to the client's mental and physical limitations. To protect the skin and maintain hygiene during the night, the nursing team decides to use an external or condom catheter. Now, the question is, when applying an external catheter to a male client, which nursing action is most appropriate to ensure both safety and effective urine drainage? Moving into the options for this scenario, Option 1 suggests lubricating the penis before applying the catheter. Option 2 advises measuring the length and circumference of the penis before use. Option 3 recommends leaving space between the end of the penis and the catheter's drainage end. And Option 4 suggests retracting the foreskin before rolling the catheter sheath over the penis. Now transitioning to the correct answer, the best choice here is Option 3. Leave space between the end of the penis and the catheter's drainage end. Expanding on this rationale, this question tests your understanding of safe and evidence-based practice when using an external catheter, particularly in clients with limited mobility or cognitive impairment. The most appropriate action is to leave about 1 to 2 inches of space between the tip of the penis and the catheter's drainage end. This small gap ensures free urine flow, reduces friction and pressure on the urinary meatus, and prevents irritation or tissue damage. If the catheter is applied too tightly or without adequate space, urine may backflow, leading to infection, meatal erosion, or ischemia. External catheters are designed to resemble condoms and are usually self-adhesive or secured with elastic tape applied in a spiral pattern, not circumferentially, to prevent restriction of blood flow. After application, the nurse must confirm that the drainage tubing is not kinked and that urine flows unobstructed into the collection bag. Frequent inspection of the skin is essential to detect any early signs of maceration or ulceration, especially in older adults or those with incontinence, because prolonged exposure to moisture or adhesive sensitivity can compromise skin integrity. Now let us briefly examine why the remaining options are incorrect to enhance your NCLEX level reasoning. Starting with Option 1, lubricating the penis before applying the catheter is incorrect because lubrication interferes with the adhesive surface of the external catheter, leading to loosening and potential leakage. Remember, external catheters are not inserted into the urethra, so lubrication is unnecessary. Instead, ensure the skin is cleaned, dried thoroughly, and free of oils or lotions before application. Option 2, measuring the length and circumference of the penis is not required. External catheters come in various flexible sizes designed to fit a range of anatomies. Overhandling the genital area can also raise infection risk. The nurse should simply choose the appropriate size by visual estimation and manufacturer guidelines rather than measuring. Finally, Option 4, retracting the foreskin before rolling the catheter sheath is unsafe and contraindicated. Leaving the foreskin retracted in an uncircumcised client can cause a tourniquet effect, impairing circulation and resulting in painful swelling or tissue necrosis of the glans penis. Always ensure the foreskin is returned to its natural position after application to maintain proper blood flow and tissue safety. Transitioning to deeper understanding, let us look at a clinical insight. External catheters are an excellent alternative to indwelling catheters for reducing the risk of catheter-associated urinary tract infections, CAUTIs. However, their safety depends on correct technique, regular inspection, and consistent skincare. Neglecting these steps can quickly convert a preventive device into a source of infection or injury, particularly in clients with reduced awareness or immobility. And now, let us conclude with a stand coast pearl. Leave room for safety. Always ensure 1 to 2 inches of space between the penile tip and catheter end to protect the meatus, maintain comfort, and promote continuous drainage without backflow or tissue injury. Let us smoothly transition into another essential NCLEX-Style clinical safety question. Imagine you are caring for a male client in the post-operative period who has just undergone insertion of an indwelling urinary catheter for continuous bladder drainage. The nurse must ensure that the catheter is stabilized correctly to prevent urethral injury and maintain continuous drainage. So, which nursing technique should be used to properly stabilize the catheter and avoid damage to the penis? Here are the options to consider. Option 1, tape the catheter to the abdomen. Option 2, pass the catheter under the client's leg. Option 3, fasten the drainage tubing to the bed with a safety pin. Option 4, insert the catheter into the tubing of a collecting bag. The correct answer here is Option 1, tape the catheter to the abdomen. Now transitioning into the detailed rationale, taping the indwelling catheter to the abdomen is the most appropriate technique because it follows the natural anatomical course of the male urethra, reducing tension and friction at the penoscrotal junction, a critical area prone to pressure injury and fistula formation. Directing the catheter upward toward the abdomen allows free body movement without pulling or bending the urethra, thereby minimizing trauma, ischemia, or erosion. Nurses should always leave slight slack in the tubing before securing it, ensuring that body movements do not cause traction or inflammation that can lead to urethral necrosis over time. Furthermore, proper catheter stabilization contributes significantly to the prevention of catheter-associated urinary tract infections, as per Centers for Disease Control and Prevention guidelines. Reducing micromotion at the urethral meatus limits irritation and bacterial entry, thus lowering infection risk. The securement device must be placed on clean, dry skin and replaced when moisture or maceration develops to protect skin integrity. Shifting focus now to why the other options are incorrect, passing the catheter under the client's leg, as mentioned in option 2, is unsafe because it can cause kinking and obstruction of urine flow. The leg's weight continuously presses on the tubing, risking mucosal trauma, bladder distension, and backflow-related infection. Moving on, option 3, fastening the drainage tubing to the bed with a safety pin, is also inappropriate. Though maintaining a straight drainage line is necessary, using a safety pin may puncture or tear the tubing and fails to stabilize the catheter at its insertion point. The correct practice is to secure the tubing to the bed linen, not the bed frame, with a purpose-designed clip that allows flexibility without tension. Lastly, option 4, inserting the catheter into the tubing of a collecting bag, is simply part of the routine drainage system setup, but does not assist in stabilizing or preventing urethral damage. It maintains a closed drainage system, but provides no protection at the penile level. Transitioning now to an important takeaway: clinical insight. Catheter stabilization is not just for comfort, it is vital for preventing complications. A poorly secured catheter can cause urethral trauma, bleeding, infection, and even long-term damage such as strictures or urethrocutaneous fistulas. Always remember, for male clients, the catheter must be secured upward toward the abdomen, whereas for female clients, it is fixed to the inner thigh. Regular assessment for skin irritation, twice-daily perineal hygiene, and keeping the drainage bag below bladder level are non-negotiable steps in safe urinary care. And finally, here comes your golden memory cue. Stand coast, Pearl. Up is safe, down is damage. Always secure a male client's catheter upward on the abdomen to protect the urethra, prevent unnecessary traction, and preserve both comfort and tissue integrity. Correct positioning is the foundation of long-term urinary safety and infection prevention. Thank you for watching. We will see you soon in next video.